Well, thank you to Murray, to Margaret, to Diane, to everyone for having me here. I am a newbie. This is the first time I've attended this conference, and I'm already so impressed, not only with the agenda, what I heard this morning, but with the questions from the audience. These are the types of meetings that I really look forward to attending, and I'm really honored that you had me here today. And Murray did mention he's my board chair, so when he said, hey, Sarah, will you come do this conference? The answer is yes, Murray. I would love to come to California and do this conference for you. But that was you guys are making that an easy yes. So what's the problem? Why are we having this conversation? Why is it that it's the top thing in pretty much every poll that we're asking consumers about what's bothering them and worrying them about healthcare? It's because right now we have a pricing system that's not anchored in prices that match what patients receive and benefit. Full stop. The monopoly pricing power that we grant manufacturers gives them the ability to price it at what they think the market will bear. Many of them do say it's tied to the clinical value. I'm going to talk through some examples of where they have said it's tied to clinical value, and we've agreed. But there's a lot of examples, and that's the red on this slide, where the clinical benefit that patients are receiving are nowhere near what the manufacturer is asking us to pay. And when we have a system like that, then we have warped incentives. We are incentivizing people to develop new drugs, but we're not going to measure how much they benefit patients. So what is the incentive? To price as high as you can to return as much to your shareholders? Sure, that's one incentive that exists in the biopharmaceutical industry, and as Murray mentioned, I spent 10 years there. But there are other reasons that we want to have prices in line with value. And I'll talk about these in a little bit more detail after I tell you how we do our math, because I think that's an important part of understanding how we come up with these numbers, or how we come up with this conclusion that we've got a problem. But I also want to highlight that sometimes the prices are in line with the clinical benefit. And sometimes those prices are high. And we don't represent, I think a lot of people in the room might remember the gentleman who ran on the rent is too damn high party in New York, and we all love that, right? This isn't the prices are too damn high. Nope. Sometimes the prices are right, even if they're high. It's when they're high and there's no benefit or very little benefit accruing to patients, or the benefit is small, or it's not much better than what we're already doing, that's when we're losing as a healthcare system. And that's what this slide says. There are times when huge discounts are needed to get to a place where we have the benefit aligning with the price it's chosen. And we're losing when we don't take advantage of trying to get those prices in line with value, because that's money we can't spend on other things. So for those of you who aren't familiar with Kaiser, just a moment. We are an independent, nonpartisan nonprofit. We've existed for 14-ish years, and we've been doing this for a long time, which is funny because we didn't get as much attention until we started looking at prescription drugs. You guys can draw your own conclusions about why that is, but we were doing this for a long time before we started looking at prescription drugs. Why did we switch to prescription drugs? We didn't switch. Why did we start doing more of our research on prescription drugs? It had a lot to do with how that part of the healthcare spending pie was growing faster than every other part, and what trade-offs employers and patients and others were making, and governments were making because of that. One of the things that makes us distinction is we do everything out in the public. We produce our reports, we put them up for public comment, we revise them, we hold a public meeting with an independent panel of experts who beat us up about the conclusions we've made. They take votes on what we know about the clinical benefit, about the comparative effectiveness, about the comparative value. And at the end of the day, the part that probably gets us the most attention is that we do not shy away about talking about cost and cost effectiveness. Some people think that using evidence and data about the cost effectiveness of a drug is controversial. We think that's just. And the other part that I wanted to mention here is that, again, this isn't about saying they're all too high. It's rewarding the innovation that brings truly transformative health gains to patients and incentivizing that innovation and saving money by not overpaying for innovation that offers marginal benefit. That's fair price. That means that payers have to give fair access to patients, and then we have plenty of money for future innovation. Just to tell you about our framework. Left-hand side, long-term value for money. Anchored in comparative clinical effectiveness. You have to answer the question first. How much better does this work from a clinical perspective than what we're already doing? There's a lot of times when you don't have to ask the next question. If it's not any better, then you can do something like reference pricing. If the new drug that's been introduced doesn't offer any additional clinical benefits than what we're already doing, why on earth would we pay more for it, right? That's the question that you can answer by asking that question. And then if you do have a marginal benefit or a big benefit, then it's quantifying the magnitude of that benefit and deciding whether or not the price is in line with that benefit. That's where cost effectiveness comes in. I do also want to pause here and say cost effectiveness cannot capture everything that matters. It's just impossible. And we've developed a system to gather potential other benefits and contextual considerations, mostly through our interaction with patients and patient groups and caregivers. These are things that are sometimes intangible, but sometimes they're just not measured in a cost-effective or in a clinical trial, and so we don't know the answer. But these are very important considerations that society needs to take into account when they're thinking about a fair price, when they're thinking about coverage. I'll just quickly mention that we also look at potential budget impact. There's only a few times when you'll have something that looks really like a good deal from a long-term value for money perspective, but then might offer an affordability challenge. There's probably a lot of people in the audience who will go, right, Hep C. Hep C is the exact example of this. From a long-term value for money perspective, even at $80,000 for a course of treatment, that was a good deal. But because of the number of eligible patients, there literally wasn't enough money to pay for it. And so when we signal that there's a potential budget impact, it's meant to say to policymakers, hey, let's have a grown-up conversation about how we're handling price, access, coverage policy in a way that isn't bankrupting states and families. I'm going to teach you cost effectiveness in 90 seconds. You ready? This is the cost effectiveness plane. It is cost and it's effectiveness. One of the values, I'm telling you, one of the ways you measure effectiveness is the quality adjusted life year. There are other ways. It could be the number of hospitalizations avoided. It could be length of life. It could just be life years. We use quality adjusted life years because it's grounded in what patients care about. How much does this drug improve my length of life and my quality of life? The blue dot in the middle is what we do now. We have a brand new drug. It's more effective and it costs more. Great. I'm getting more qualities. I'm getting more length of life and or quality of life when I take this drug, and I'm paying a little bit more for it. Okay, sure. I have another one. It's even more effective, and it's slightly more expensive. How do I know which one is of high value? You draw a line. The health maximization threshold, through research from health economists, is the line above which, when we start paying more, above this line, people are harmed because they cannot afford insurance or they become more underinsured. So that causes net harm to society because of how premiums increase in terms of increased cost. You can draw this line a couple of different ways. We use a threshold of $100,000 to $150,000 per quality adjusted life year gained. So you do a ratio and you put that into a 1 unit. There are lots of other thresholds. The UK uses 1 times gross domestic individual per capita GDP. It's about $30,000 to $40,000, I think. I always screw it up because the exchange rate keeps changing. The World Health Organization has talked about drawing this line at between 1 and 3 times per capita GDP. Individual policymakers can decide for themselves what they think the appropriate threshold is, but the idea is to say there's a point at which when we spend more, we have net harm to other patients. And here's the really important part, and the only thing you take away from my talk today, it's not that so now we've got the second yellow dot above the line. It's not that we don't want people to access that drug. It's not that we want coverage policy to say you can't get that drug. It's to say, bring down the price so it becomes below the line, and then everyone gets access. So you just learned cost effectiveness in 90 seconds.
Left a little out.
Just again, when we've done that analysis, and we've applied it to over 100 drugs at this point, just looking at some of the drugs we did in 18 and 19, you see wide variation in how the price picked by the manufacturer aligns with the clinical benefit. And so the percent discounts you see here in red are the discounts we'd need to get that yellow line to come below that health maximization threshold. But again, there are times when we have expensive therapies that are actually cost effective. And we want a health system that has the resources to pay for them. And we can do that when we stop overpaying for either Me Too drugs or drugs that offer only marginal clinical benefit to patients. Just a few minutes left to talk about how people are using this work. And this will be, I have to say that Hammy and Christoph later this afternoon are going to totally school me on everything that states are doing for this work, with work on prescription drugs, but I will talk about what we know has happened with some of our work. So New York Medicaid passed a law a couple of years ago that put their prescription drug spend on a cap. Basically said it can't rise any faster than this. If they identified drugs that were piercing, the spending was piercing that cap, they had the authority to ask the manufacturer for a supplemental rebate to then bring the price down to decrease spending. If the manufacturer refuses, New York has several things in its arsenal to use to then say, okay, this is the price you will give us. This was the supplemental rebate you will give us. And one of the things they're allowed to use is independent analysis of comparative value and cost effectiveness. So in the first year, they identified 30 drugs from 12 manufacturers that were piercing the cap. And you can draw your own conclusions, but only one drug got referred to their Drug Utilization Review Board because they refused to offer a supplemental rebate. The conclusion you should draw is that all of the other companies gave a supplemental rebate and they were able to extract some savings for their Medicaid department. That one drug was Orkambi for cystic fibrosis. When we happened to be doing a report of Orkambi around the same time and were contacted by New York, we came to their public meeting and presented our findings. And we were invited to testify and present our results. And what we said was, here are the discounts you would need to bring the price of Orkambi in line with the clinical benefit that patients receive. And the Drug Utilization Review Board in New York said, okay, that health maximization threshold at $150,000 per quality adjusted life year is the line we're going to draw, and that's the supplemental rebate that we need. This happened in April of 2018. I have heard recently they're still negotiating. So I'm not going to declare victory, and it really isn't about declaring victory as much as it is about giving states something to pin their negotiations to. Because again, if you just default to the rent's too damn high, then you walk into a negotiation and you're like, I think your price is too high. And the manufacturer says, no, it's not. And so what we really strive to do is to give this information to anyone who wants to use it, but especially public policymakers, so that they're anchored in something that is based on what the benefit patients receive is. What's really fascinating is to watch what happens next. Everyone was watching New York very closely. They've renewed and tweaked their law for the last 2 years. So this is the third year I think it's been implemented. They continue to use this law to get supplemental rebates, and they still have the ability to refer drugs to the Drug Utilization Review Board if they need to. But last year, Massachusetts passed similar legislation giving authority to its Medicaid department, known as Mass Health, to negotiate for supplemental rebates and have a pathway for a public hearing of sorts if a manufacturer won't give them a good deal. Everyone's watching really closely to see what happens next. Draft regulations are out, but there's a ton of interest to see what Massachusetts will do. And I think as happened with the Affordable Care Act and other things, there's a lot of let Massachusetts, and in this case we'll put New York in that category, to do it first, and let's see what happens, and let's see if other states join them. I bet that Hammy and Christoph will probably touch on this later. Maybe some of the other speakers will here today as well. But the other thing that's happening is states aren't waiting for federal legislation for trying to solve this problem. So the other thing we're seeing is prescription drug affordability boards. Maryland and Maine have passed laws authorizing the study and potential implementation of this. This would be modeled after a bit of the rate-setting approach that Maryland is very well known for in the hospital side, where they would set an upper payment limit for drugs. There's a lot of us who are very curious to see how this gets implemented, what kind of information that they'll use to set those upper payment limits. But I think what you're seeing here is frustration and lack of tools that they think they have in order to deal with this issue. And then the other thing that has been talked about a lot, and a lot of legislation has already passed, are around pharmacy benefit managers, gag clauses, transparency, and I'm fascinated about the reimportation question. Maybe John will talk about that a little bit. Just what that would mean. Will Canada let us buy drugs from there? I'm thinking no, but like sure. Like this is one of the things that states are looking at. Again, I think this is just symptomatic of they're feeling a little bit helpless. They're feeling as though, as they watch their drug spend eat bigger and bigger portions of their Medicaid pie, they're making really difficult choices about what other services they can't offer. And I think they're feeling like it's time to try something because we've had such growth and problems with access and providing other services that we want. So what do I see as the future here? I think there is a possibility that we can achieve the grand bargain. The way we talk about the grand bargain is a manufacturer chooses a price in line with the clinical benefit and puts pressure on the payer to make sure patients get access. And we've seen this happen. I now have 5. I'm really excited to get to a second hand when I want a 6th example when I can hold up 2 hands. But we've had Dupixent from Regeneron and Sanofi, a drug for eczema. Praluent, a drug from Regeneron and Sanofi for high cholesterol. Amarin has a drug for cardiovascular disease. Novartis with its Zolgensma gene therapy for spinal muscular atrophy. And there's hints of what will happen with the new Bluebird drug that we're currently reviewing for beta thalassemia. We have examples of manufacturers saying, we did the right thing. We picked a price in line with ICER's analysis of what a fair price is. Hey, manufacturer, you have to do, hey, payer, you have to do the right thing and give access now. No more crazy prior auth. No more making somebody with CF take a second genetic test to prove that they still have CF, right? Like, there's just some things that we do that don't make any sense. And we think that our work can really be the impetus for like demanding that fair price, but also demanding that fair access. I think the pipeline of gene and cell therapies, and I think we're going to get to this in our Q&A, and maybe you guys have questions on this. This is probably the scariest part of what we're doing because these potentially curative therapies that were either short-term or single therapies in traditional cost effectiveness could have a lot of zeros after their fair price. But we all know that that doesn't make logical sense, that charging $80 million for a cure for hemophilia does not seem like a good use of communal money for paying for healthcare. So we do have adaptations to our own framework that I can talk about if anyone's interested, about how we would address those issues. But this is really, really important and I think is going to stay front and center moving forward. We also wanted to mention that price increases continue to get a lot of attention because cognitively it's really difficult for people to go, I don't understand, you launched the drug at $40,000 a year 15 years ago, and now it costs $80,000 a year. I was making $40,000 a year 8 years ago, and I'm not making $80,000 a year now, right? Like, people can cognitively be like, I don't get it. That's more than inflation. How can it cost that much more to make the drug, or why did the prices go up? Our analysis actually showed 7 drugs in 2018 and 2017 had price increases that weren't supported by evidence, and it amounted to $4.8 billion in extra spending in the healthcare system. I think ensuring a functional generic market continues to be really important. I do want to applaud the manufacturers who came out publicly, I think just yesterday, to criticize another manufacturer who bought a previously used drug, kind of told or claimed it was an orphan drug and then jacked up the price significantly. And the fact that manufacturers are calling out that type of behavior for something that was previously available at a generic price, I think is really important to ensuring a functional generic market. And I can't wait to hear from John and Liz and Wendell about what they think the impact of the upcoming election might be on federal policy making, because I am not going to predict that. Thank you all very much.